1 in 6 people worldwide experience infertility during their lifetime, highlighting the global prevalence of reproductive challenges. Welcome to the Women's Health Uncovered podcast. I'm your host, Mariam Harutyunyan, and in this podcast, I sit together with doctors, researchers, policymakers, industry leaders to bring you conversations that matter, to make sure that you can learn more about women's health and how that impacts all of us. In this episode, we will unpack the current state of reproductive health, from infertility and education to ethical dilemmas, misinformation, innovation. What do we all need to know? It's time to uncover the path to better women's health. And I will be joined today with 2 remarkable guests. Professor Dr. Shari Mackens is a fertility specialist at Brussels IVF, the Center of Reproductive Medicine at the UZ Brussels University Hospital. Welcome, Shari.
Hi, Mariam. Thank you for the invitation. Very happy to be here.
Thank you. I have a quick question for you. What word encapsulates the global journey of reproductive health today? One word that comes to mind.
Challenging.
Challenging. Why did you choose that word?
Well, because it's challenging from multiple perspectives. From our side as doctors, researchers, but definitely also from the patient's side.
Well, I'm excited to learn more then when it's challenging. Olivia Natens is my second guest. She is Senior Vice President at Vitrolife Group, a global leader in reproductive health technology and innovation, contributing to creating sustainable growth in healthcare in general. I have also a quick question for you. Welcome, Olivia. Mm-hmm. If you could describe the current state of fertility care in one word, what would that be?
Opportunity.
Opportunity. That's hopeful. Why did you choose opportunity?
Because there's so much change that has changed over the last years.
Yeah.
Things that were not possible a decade ago that become possible today thanks to innovation, thanks to research. So
that's hopeful. That's hopeful to get started with. First, before we dive into this conversation, let's debunk a myth. Shari, I will just read this sentence and let me know why it's a myth and what's actually more to know about it. You know, women usually think, I will wait until I am 35 years old because after that there is IVF, I can try it in a cycle and I will get pregnant. But that's not true, is it?
No, that is definitely not true. So also IVF works actually better when you're below 35. We have much more oocytes, much better oocytes. And it's really a misconception that when you are older, IVF will fix the fertility issue. On the contrary, we have much less oocytes. We see that there are problems with the quality of the oocytes, and it becomes, this is why I said challenging in the beginning, at older age, often a very long journey without certainty to succeed.
Mm-hmm. Because if you would, so the quality of the oocytes decreases after 35, and that's the main reason why it's challenging?
Yes, that's the main reason. So it's quantity and quality. So the problem, and this is why we as females differ from males, the problem is that we are born with our entire reserve in oocytes. And so we never create new ones. We only lose all of the time, 1,000 per cycle. Although we only ovulate 1, we lose a huge amount of follicles. And the problem on top of that is also that oocytes are blocked in a phase of division. And only restart this activity when they ovulate, when they get fertilized. And this is the main problem. This is what goes wrong actually with older age. And this leads to chromosomal problems within the embryos. And so this is the main reason why it's so difficult to succeed with older oocytes.
Yeah, so if I understand correctly, it's not that it's difficult to get pregnant after 35. So it's not that the success of IVF decreases itself. It's that the quality of the oocytes decreases. So if you would then retrieve oocytes before 35, that will still keep the quality or the success rate high?
Exactly. So it is not really the uterus that ages. So if you have younger oocytes, maybe your own oocytes that you have cryopreserved before, if you use them, if you would thaw them, if you would fertilize them, they keep the potential of the moment that they were vitrified.
Oh, right. Indeed. Yeah. So that's the reason. Olivia, Vitrolife Group works across the world. What shifts are you seeing in access or expectations when it comes to fertility?
Well, it's very different from an access perspective across the world. From actually, we are pretty well insured and well covered in Europe. It varies across countries. Every country is, of course, different within Europe. but access is well covered. When you look to the States, for example, where it is hardly covered, where Mr. Trump is making big promises now, but nevertheless, insurance is only partly there. This means that IVF is for the happy few because it's pretty costly. We're talking $15,000 per cycle, and you probably need more than one cycle. Over Europe up to Asia, where insurance, for example, in Japan is well covered, but very strictly regulated. Also limiting things to patients as to access to certain medication or treatments. And then when you go down to Pacific, Australia, very well covered. Looking to China, where the authorities have recently changed and they saw that they had to do something. So reimbursement is getting installed. But also there today, it's not a solution yet because the whole system needs to get adapted to the new processes.
So your life decisions actually depend on the regulations or the reimbursement of it.
There is lots of patients traveling around the world exactly for that reason.
And do you see that more people are seeking fertility care, or are they still waiting too long?
That's $1 million question. I think today it's part of our, I would say, duty to educate more and more. Also, one of the good reasons that we are here, and thank you for that opportunity. Because there is misconceptions still today. And there is also this blame, this shame thing, culturally very different from a religion perspective, very different what is allowed, what is not allowed. So do people know more? Definitely through the web. There's lots of information there. Hence, patients are today, and you can probably testify, are much more educated and knowledgeable. But then we've got Dr. Google, who potentially also has not the right information. So there's still a journey to go there.
How do we tackle that? The misinformation spread by Dr. Google or
it's a very important issue, what Olivia says now. So indeed, there is this huge bank of information, but a lot of that is misinformation. And we see this on a daily basis at consultation. Last week, one example. So we had a very young lady. She came to freezer oocytes. She had a beautiful number, actually a completely correct number of 15 oocytes cryopreserved. And she was crying after her oocyte retrieval because on TikTok, she saw everyone having 40 oocytes. So she thought that this was a cycle that did not go correctly, while she had a beautiful result, actually, in normal medical perspectives. So I think that we, as experts in the fields, as medical professionals, should maybe also consider to be on TikTok, because we need to get the correct information to the patient. It's not just the information. I think there's a lot of information, but also a lot of misinformation. We see this on a daily basis. Also patients that take additional medications not being prescribed by us, for example.
Thinking it will help.
Because they saw someone on social media saying aspirin, for example, is a typical example. If I take some aspirin, my chances of implantation will be better. So far, we have no evidence for that, and also no evidence that we might not harm or have more complications, for example. So it's crucial to get the correct information.
And also just translate that medical information in an understandable way. I think it's easier for them to take that away from TikTok or social media because it just says aspirin is good for that. And then, you have the medical terms that are much more difficult to process.
And there's also role models. So you see that a lot on social media. And there's countries in Asia that are renowned for that. Once there is or also in the US, once there is an actor or somebody who has a lot of followers who has gone through IVF and then shows or shares a lot of information, her personal story, that triggers a lot of, I guess,
it's often
questions.
Often quite complex things that we need to explain, and indeed, it's key to get that across in an elegant way that is understandable for everyone, and not only among scientists. And
on the other hand, if they do that, it makes it more easier to talk about. It opens up the conversation when you see those figures talking about, their IVF journey. It comes closer to people. For awareness awareness purposes, it's a good thing that the information is spread
forward. But if we could back that up now with correct medical info, a little bit additional, a little bit more complex.
Yeah, perhaps also not oversimplifying, because sometimes the messages that we pick up then through our channels, because we also get questions from patients through our channels. Yeah, that sometimes you see that it's oversimplified.
Yeah.
It's never black and white.
No. Yeah, it's a much more nuance needed. You were talking about, Olivia, the reimbursement. Are there other gaps that you are seeing in reproductive health access globally?
I think reimbursement, we have that conversation with doctors and IVF centers across the world. And when we ask, what is the main barrier? Yeah, it's basically the money. Yeah. One is, of course, getting the right information. But then if you need IVF and you are not the happy few who can afford, that's where it becomes painful, of course. So that is a main barrier. Now, we also see there was a big surge after COVID. So there was a delay of IVF treatments and cycles because of the reasons that we all know during COVID and healthcare system. But then now we start seeing a steep decline of what we call the cycle growth across the world. And to answer your question, that may also be the uncertainty of the political environment, the wars around the world. People, cost of living. Not only have an IVF cycle, but also raise a child, bring that child through school years. It all is part of a bigger picture. Yeah.
You mentioned cycle growth. So what are you talking about when you say cycle growth for our listeners?
Well, there's different definitions, and you probably can help me there. It depends on whether you count the oocyte pickups, the OPUs as we call it. But you can also count the cycles. So how many cycles does a lady need to go through before pregnancy? If we look at OPU growth, we take that one. Because it's also difficult to compare across the world, and you want to be sure that you compare the right things, is that we see a slow but steady decline especially post-COVID, where that was a huge surge. Yeah.
What's driving the decline?
It's a difficult discussion, and we don't really know how to interpret, as Olivia said. One thing which is, of course, very important is that the vitrification techniques, the way that we can freeze embryos, this has made a huge step forward over the last 10, 15 years. So what we typically see is that there are less oocyte retrievals, but there is a huge increase in the number of frozen embryo transfer cycles. So it is not that easy to get all of your key performance indicators next to one another and really make a conclusion on whether this is going left or right. One thing, and this is something that we typically see and have the possibility to evaluate in Belgium. So in Belgium, for example, you have 6 of these oocyte retrievals reimbursed, which actually means that you inject medication for 10 to 12 days. Then your oocytes get picked up. People in Belgium can do this 6 times, so 6 times per female. Yeah.
And is that enough? Is that enough to cover the average of success rate?
Of course, if you did 6 oocyte retrievals and you are not yet pregnant, and then definitely of your first baby, the chances they go down. Okay, yes, they go down. Yes. It means that you don't have a lot of oocytes, that there are not a lot of embryos. Most people, depending on the age, which is the essential factor to which we always come back, most people are helped. It's one of the most liberal systems of reimbursement that we have in Belgium. Nevertheless, we also see that there are a lot of couples not using their 6 cycles. And this is probably because of the huge psychological impacts that it has to do IVF.
Not using the 6 cycles? You mean that they drop out? Because
there is a huge dropout rate. So they do 2 cycles, 3 cycles, some only 1 cycle. And then we think, why don't they come back to the consultation? Actually, their chances are quite high. But still, and this is a working element for all of us, I think. It is the way that they experience the treatment, how it interferes with their life, the emotions, the hope.
So the system around it is not then well designed.
No, I think that there is really advancements that we could make in psychological counseling, not only your medical doctor who guides you through your treatment, but also a psychologist who is next to you.
Yeah, a more holistic approach.
A much more holistic approach.
Yes.
Yeah.
And what we see is also that the average age of women seeking fertility care in many countries is rising, yet fertility starts declining after the age of 35. What is also the current age of women seeking fertility care or passing the clinic?
Well, in our clinic, it is still quite okay. We're still below 35. We're at around 33, 34 years old. But one of the main reasons is that a huge part of our IVF program is actually young couples doing IVF because they need a genetic test on their embryo.
Okay.
So not all people who go through IVF have a subfertility problem. And so 1 out of 6 of our cycles is because of that reason. And that, of course, lowers immediately the maternal age. We, of course, also see that the indication coming later because you are older and because you are not conceiving spontaneously anymore, that also increases, of course.
We see big differences across the world on maternal age. And so Europe is around, indeed, 30, 32, 35. When you then go to Asia, Taiwan, average age is 42.
Okay, that's much higher.
That's average.
Yeah.
So that means there is elderly ladies as well.
What's the reason of that shift, or what's the reason that it's so high?
Because of people delaying. There is this strong, I think there's an economical reason.
Yeah.
There is ladies who want to first earn their money and have a life, and then all these, motherhood becomes delayed. There is also the cultural piece. You don't start early in those areas of the world. But it's striking. Asia is much later. Same in Japan, like beyond 40.
Also in Southern Europe, for example, if we talk to our Italian colleagues, for example, the maternal age, when they do pickups, it's at mean higher than what we typically see.
Okay, that's quite...
There's also limitations with reimbursement across, so that probably can also be an indicator why people find their way faster or relatively faster than...
Yeah. And you said the reason why people go through an IVF journey is not necessarily infertility. Who is passing by the clinic? What are the profiles of people that are seeking that support?
Well, the typical profile is still the couple that has tried for 1 year, 6 months, if you're above 35, and that then comes for their workup and enrolls in IVF. But for example, what I told you before, the genetic testing of embryos is, for example, a family in which a cancer gene is known. So a risk factor that is there that you do not want to give actually to your children, to the next generation. So then we have PGT, which is pre-implantation genetic testing. These couples, they are not infertile. They go through IVF like a subfertile couple would do. These embryos are created, and then you can actually harvest 5 to 10 cells of a growing embryo to check that specific mutation. We cannot change these embryos. We cannot CRISPR, but we can deselect embryos, and then we only transfer the ones that do not carry the mutation. Yeah.
So what is PGTA being implemented for? Is it specifically for that genetic embryo screening, or are there other reasons?
There are different types of PGT. Yes. So the PGT that I was talking about before is...
What does PGT stand for?
Pre-implantation genetic testing.
Okay.
And you have actually 3 forms.
Yes.
Okay. You have the M, with M of monogenic disease. This is the example that I gave you before. There's one specific mutation, and this is checked. And then you have the PGT for chromosomal reasons.
Okay.
And there you have the SR, which comes from structural rearrangements. These are people who have a translocation. Okay. In simple words, small part of a chromosome is stuck at another chromosome. It's already becoming complex, but it gives them much more chromosomal aberrations in their embryos. And then the last one is the PGTA, where the A stands for aneuploidy. And this is typically the technique which can be elegant to do at older age, because these women the problem with the quality of their oocytes, that I told you before, this leads to aneuploidy. So these embryos, they don't have 46 chromosomes, 47, 45, because of these errors in splitting their chromosomes. And this is the main reason why these embryos do not implant. So there the chromosomal cars actually of these embryos are created. Yeah. And this is something which is in some countries done routinely, for example, in the US. In our case, in Europe, this is not the case. There are even some European countries where it is illegal, where it is not allowed.
So we have all this data, but we cannot use it here in Europe then?
We can, but here we do it, at least in our center, on indication. So when you have had a lot of failed embryo transfers, a lot of early pregnancy losses, but it is not that all embryos are checked genetically. But at some point in your journey, it might become an elegant technique to get the time to pregnancy. It's also a very important key performance indicator. How quick can we get you pregnant?
Because one of the other differences is that in the US, for example, you can also make the decision, you're screening between gender and decide that here we can't do that.
We cannot.
No. Where do we draw the ethical line of, the screening before? You have the genetics, you have the chromosomes, but you have also selections that you can make.
The fact that the standards of care are already so different, whether you are in American continent or Europe, for example, or Asia, you always see the three big parts of the world. And that where scientific societies prevail genetic testing, specifically PGTA, as a standard, for example, in the US, where in Europe that's not the case yet. That means that there is a lot of debate still to have. There's also people who travel the world in order to have those tests because we know that it's available. And then, of course, it's also the quality of the labs. We need to be sure that these tests are done by experts in labs that are respecting the rules. All that is, of course, very important. Yeah. And probably also worry, I think, in Europe that quality needs to be there.
Yeah. It needs to be. You need to know what you're doing. Of course, if you do PGTA, to not go into the details, but there is still a lot of discussion.
Yes.
The worst thing that could happen with an embryo selection technique is that you discard an embryo which might have been the embryo that you need. So it needs to be done in expert hands. And patients, they need to be aware of the pros and the cons. They need to be fully informed. And something else where we need to be careful about, and definitely at the level of the genetics and the huge progresses we see in genetic research, is that, before you make something a clinical routine approach, all of the studies need to be done. We need to be completely sure that we are. It's not because it's new and because it's hot and because it's the most innovative technique that necessarily the correct evidence to support it is already there. So it's and it are very complex issues to discuss with patients as well.
So genetic tests always need to go through genetic counselors. It's also depending on what part of the world you're in, where it actually is legally obliged. If you offer a genetic test PGTA, for example, in the US, you have to offer genetic counseling. And you're right, it's never black and white. It's always an interpretation, and this recommendation, the discussions that these experts have with patients is very important. And also with the doctor, of course, who ultimately makes the decision.
There will probably never be one technique that fits all. It will never be PGTA for all, or because you need to individualize this technique. Does it really offer an added value for that specific patient? Because if you are older, of course you want PGTA to check for the chromosomal cards of your embryos. But if there is only one embryo, there is also no selection possible. And then the patients, they need to decide, but okay, if this is a embryo that will give me a high risk of not being pregnant or having an early pregnancy loss, they need to be able to decide that together with you. Maybe not from the start, but if it is a couple who experienced already 4 or 5 pregnancy losses, I can fully understand that they want us to check it.
So it gives you at least information.
It gives you a better vision, and you can interpret the clinical case better.
And there's also other technologies, like the whole time-lapse technology that is now very much available across the world, has become the standard of care, I would say, in Europe. Okay. It's also one of the one of the strengths of Vitrolife Group is that where the time of culture, the famous 3 to 5 up to 6 days that an embryo is being formed, that can be done now in a system that is closed. That and there's also already artificial intelligence that we can put at the service of embryologists. It never replaces the judgment of an embryologist, but it can facilitate the task at hand, because it's always the goal is to select the best embryo that has the highest chance of implantation, and hence ultimately gives a healthy child.
Yeah, because AI does offer new possibilities for diagnosis, treatment, personalization, even because you said, it's so broad, there is so much nuance in it. It also depends on the person. So it can help probably somewhere in there. And it is already being used in fertility labs to assess embryo quality, goal of improving IVF success rate with that final goal. And you also mentioned a bit of what the Vitrolife Group is doing in this area. What are other implementations of AI solutions or technology solutions that you see are coming up?
Well, I think we're only at the start. It's the same with everything we know in life, actually.
Yeah.
What we see is that there is so much data generated as well in a lab. So once the oocytes are picked up, these gametes, as we call them, are then handled within the 4 walls of an IVF lab. Which is highly protocolized, highly quality system driven, but still there can be a lot of more data generated. Still very manual today, if I may say, if I compare to other pathologies.
So, this is only the lab side. So before these gametes come into the lab, you have the full stimulation protocol, where we also have a lot of data, hormones, ultrasound scans, patient characteristics. So in an ideal world, which is probably lying in front of us, all of this will probably interconnect, and we will learn a lot from these.
That's what we call the ecosystem. That's also one of the strategic drivers of our company, because we with the technology we're already selling today and the technology that we're developing in our R&D, we see that the power is going to be with interlinking all that information, the same as everywhere with the Internet of Things, and then digesting out of that the right recommendations. What is the right parameter to look at and what do not consider. And then connecting all this information and also the equipment and the tools. Again, it will increase quality. It will reduce human error, because there is also an element of human error sometimes. It sadly enough happens in the world. So technology is one thing. Data connectivity is fundamental. And then, the ITers need to talk to each other and make all these universes connect, which is not an easy thing.
No, it needs to be clinically applicable. It all sounds very good in theory, but before you have a system working at your clinical floor, there is and this is often like this in research. So you have your very first study and everyone becomes very excited, but it's the translational aspects of all of these things that is the most difficult thing.
How is AI affecting your work as a fertility doctor, or is going to affect your work?
Probably. So for now, we still do a lot of interpretation ourselves. In the lab, the scoring of embryos with time-lapse is used more and more. And from our side, so now it is still the doctor that interprets certain blood values, hormonal values, for example, ultrasound measurements, to, for example, decide the moment when you want to pick up your oocytes. This will probably be done by an algorithm in the future.
Well, making it maybe faster to get to that point where you can implement your own expertise. Can you share another example of a technology that you're either researching or implementing?
Well, I cannot diverse on what we are, of course, doing in R&D, but it's all about digitalization, and there's a lot about automation. Because, I repeat, it's a very manual process. People need to be extremely trained, and there's years of expertise to be built up.
In the lab, there is a huge learning curve.
So the more we can standardize, the more we can automate. That's also a driver for us. And that's also what is being recognized across the world as things that need to happen to further advance IVF and outcomes.
Yeah.
And then there is the whole research piece, because you mentioned it. One is technology and then trying it out and taking first steps, but then seeing is believing. You need to do studies to and then show and validate that your assumption is right and that the technology proves. And we're happy that we have, for example, a big study that proves the quality of what we call the IDA score, the AI algorithm, and it is of the same quality as expert embryologists. And then there is the gain of time, because also there's more and more patients. So there is people that need to be trained in the labs, nurses, doctors like you. We know that since COVID, there's scarcity in healthcare professionals. So the more we can, the systems can help and win time, I think is part of the solution there as well. And then to answer your question on artificial intelligence, we know that we are, for example, looking very much at embryo. I know there is technologies looking at the oocytes. Already there's technologies looking at sperm quality. So it goes across the whole cycle of care.
Yeah. And we're talking about data collection and, of course, using technology to assess some kind of things. How do we balance innovation with patient trust as well?
Yeah, I think that the confirmation studies that Olivia just referred to, they are essential. Patients, they need to fully trust, of course, the process that they are following. And many people are a little bit afraid of AI, that it could replace their task. But I think that from an embryologist point of view, nor from a doctor point of view, it will never be the case that we are not needed. The AI will always be your assistant, but of course you make a final decision. You need to get your patients on track and explain everything. And I really think that there is a helping role for all of these technologies, for seeing that we can be more efficient and perhaps also more consistent, less interpersonal variability, all those things. So there's value that AI brings. But it ultimately always remains a tool. And that will always be guided. It will always be a connection between what is there now and how these future technologies will look like.
We have been talking about reproductive health and focusing a lot on oocytes, on women's health, on the cycles. But that's only one part of the story. And it's also interesting to highlight that other part, because studies also show that, if I'm not mistaken, 40% of infertility cases are also linked to male factors. Yet most treatment protocols still center on the women's body. And even a couple, when they go through infertility or they can't conceive, usually the woman goes through treatment. But I really would love to highlight the other side as well. What about male fertility?
Yeah, it's an excellent question. And because, of course, we have IVF, you can never catch oocytes if you do not stimulate. So even if it is for a pure male infertility, well, the treatment for the lady is exactly the same. She goes through the stimulation, etc. And definitely because of the ICSI technique. So it's a technique in which one sperm cell is injected in the oocyte. Well, you only need one. And because of this technique, we can fix a lot of male problems. And this has put on hold on research, investigating why sperm quality is lower, how you can maybe increase the sperm quality, because, well, the solution is actually there. And it is true that even still today, most of the fertility specialists, well, they come from a formation of being a gynecologist. And also from a psychological point of view, it is sometimes very frustrating that the man is a little bit put out of the story, while, again, we should go for a more holistic approach. For example, the paternal age and lifestyle of the male.
So we don't even have enough research for that part of the story.
No, there's still a lot of research that needs to be done there.
And
definitely.
What's there? What do we need to know about that part? Because we know, after 35, there is also the quality of oocytes that decreases. What do we need to know about male fertility? What do the listeners need to know? Something they can take away?
Well, what we think that we are seeing now is that, for example, for a long time we have worked with these very basic sperm cell analysis. Very simple. Concentration, mobility, forms. But also there, you see, for example, DNA fragmentation today can be tested. It gives you a impression of the quality of the DNA within sperm cells. Also there are devices that can filter prior to treatment. And there we have high hopes that we can learn more about sperm cells and how they affect the embryo quality as well. It is true that as of the age of 45, sperm quality also goes down, and that lifestyle, for example, smoking, obesity, etc., play a huge role in getting pregnant, but also, for example, in early pregnancy loss. While almost no one is aware of this. Often couples think, well, but we do conceive and we do conceive spontaneously, so my sperm cells will be okay. But this is not necessarily true. That it is a huge gap in knowledge today.
And do you focus in R&D also on that side, on male fertility?
Andrology, as we call it, is today also definitely an area, a segment, as we call it, that we're looking into, because it's part of the problem and hence also part of the solution.
We have a question from the audience. What they wanted to know is how you view the future of male contraceptives. Because there is also a lot, the growing skepticism around the pill. That's also something that's happening. Less and less women are willing to take the pill as contraceptive. And then you have the other side of the story, the male contraceptive. But maybe first, what's the growing mindset and social acceptance around the pill?
Well, I think that the social environment that we will have in the future will again allow research for male anti-conception. I think that also there, not a lot of progress has been made because up until now, there were probably not a lot of men ready psychologically to go on anti-conception. And I do have the feeling that this is a discussion that is slowly turning in society, and probably in the future it will be much more a mutual decision on how a couple takes care of their anti-conception. It will probably not be a women's only task to take care of. Well, at least this is what I hope to see in the future. Of course, the social setting needs to be ready before research will probably jump in to that. This is why it's taking such a long time.
What's your view on that, Olivia?
I think the fact that already today is being recognized, it's not only a female problem, is I think fundamental. That's the first step. We're not a pharmaceutical company, so I cannot talk on that matter. But that culture is changing. There's much more openness, much more equality, at least in the Western world. So there might be openness to do so.
If there is a demand, there will be progress.
Well, apparently there is no demand from the male side because if, as you said there, to put something on the market, there needs to be a market for it. There needs to be the demand for it. But apparently when it comes to and societal norms as well and the pressure and whether apparently, men not wanting to take the pill because it doesn't make me man enough or because of XYZ reasons. If there is no demand on that side, there will not be a product, but that does not really solve the issue.
No. We need to debunk myths, as you already said multiple times, and there are very good female anti-conceptions, of course. I also think that we have to be careful, for example, for the oral anti-conceptive pill. Again, the message that is coming across now is that you have a lot of side effects, but this is not for everyone. Of course, there are women who are very, very happy under their pill, but it needs to be a very individual choice. And the more options you have for anti-conception, better. And it is a pity that for now.
But is there a decrease in use of it?
Well, I think in the young generation, there is. And I am also a bit concerned that it is because of a social media influence. I'm not fully sure whether it's always based on correct information. There are also
as a mother of three daughters,
advantages of some anti-conceptions, of course. Yeah. But
there's a lot of information again on the internet.
There's a lot of misinformation as well.
Yeah, okay. That might be the reason. Because there is indeed like the movement happening, the crazing. And then the question is, why only women? Why not men? Yeah. You mentioned that, your chances decrease after 35, but maybe that's not the only reason, because I want to dive into if surrogacy is also something that you come across, how much does it happen, and if it's a possibility, and in which cases?
Well, for now, we do a lot of IVF cycles, a lot of oocyte donation cycles. As I told you before, lower number of eggs, lower quality of eggs. Most couples are helped with an oocyte donation. If you change the gametes, the uterus doesn't get old. So a surrogacy is mainly reserved for cases in which there is, and this is quite rare, an absolute uterine factor. So being born without a uterus, having had cancer, having your uterus removed, or for a gay couple, of course, they don't have a uterus. And their surrogacy is, of course, needed. And there in Belgium today, we are still in a very, very delicate and difficult political climate, of course.
We need a lot of policy changes around that.
Exactly.
We see that across the world. World. It's not where we kind of stand out as being exceptional. And it's also a lot of ethical debate as well.
It is indeed a very complex process, of course. So what we offer is high technology surrogacy, which means that the oocyte needs to be picked up in an IVF cycle, and the oocyte needs to be from a different lady than the lady who carries, avoid to lower the psychological bonding with the baby. So, but for now, the treatments that we do, a few a year in a couple of reference centers throughout Belgium, is purely based on the trust in between all of the partners in that process. So it's a very labor-intensive process if we guide a treatment like this, because we need doctors, but we also need psychologists, we need legal counseling, because the framework is not there. So it needs to be, it's a very complex thing that needs to be done in a huge amount of trust.
Why are we so much behind on a framework?
We're touching upon this on surrogacy.
It's a very delicate
matter.
It's a delicate matter, but it is an urgent thing that needs to be settled, because the requests, of course, they are only increasing with time. And when you start to debate how it should be organized, then you start to feel also why it takes such a long time. It is not easy, but clearly there needs to be a legal framework. Because for now it's very, very difficult for us, even if we want to guide. So in Belgium it is not illegal, but there is also no framework for it.
And you mentioned that that it's in different parts of the world. But maybe just on another topic, what are some, whether it's inclusive policies or restrictive policies that are happening in the country, that they're happening in the world, that we can learn from in other countries, that we can implement for Europe, for example?
Well, there's one that is like leading the world in IVF and also surrogacy and all these discussions and liberal thinking. That's Australia.
Yeah.
When I was there, it was like they're already decades ahead.
What are they doing better?
I don't know whether it's better, but they are. It's also a cultural thing, probably.
Yeah.
And I also think it's a natural phase that you need to go through as policymakers as well. When you see that things can be done in the right way, at each time medicine takes steps, and hence things are being put in a different frame. But from a thinking or liberal thinking perspective, they're ahead of anywhere that I've seen in the world until now. I would like to come back a bit closer to us, where we say, yes, we're lucky that we are in a well reimbursed, a good healthcare system. And I've seen a lot of healthcare across the world, and we can, as we say, kiss our both hands that we're in Belgium specifically. But if you then see Europe or even in countries around the world where there is reimbursement, the levels are not always at the level they should be. They were set at a certain moment in time when technology was available at that time. Since then, a lot of things have changed. So perhaps there's also something to reflect there, because we have the information. There's labs around the world who start piggybacking what product are they starting to use in order to be sure that it fits with the reimbursement envelope. And then we're not doing right care, I think.
Yeah. These legal frameworks and reimbursements, they will always need to evolve in time. So also the reimbursement setting as it is now, it has been there for years. But in the meantime, we have a lot of alternative indications. So maybe we should turn down a little bit of some reimbursements, but cover new ones. So this is, it's also difficult. As for example, donor gametes surrogacy, it's all one part of a much bigger project if you think about legal frameworks and reimbursements. But of course, all is reproductive healthcare. So you should take into account all of these things for that moment in time. And it should be flexible throughout time. But of course, if something is not very flexible in time, it are political decisions, ethical frameworks and reimbursements.
We see across the world that there's standard reimbursement, and then if patients want their embryos to be cultured in a time-lapse system, it needs to be paid out of pocket. Same goes with embryo glue, which is a proven product. There's these pieces that again, if you can afford to do this, it is okay. But then there is people who cannot. And should we then have this 2-layer of medicine? Probably not.
This is also a very unique setting in Belgium, because in most other countries you can go for your IVF in a public or in a private setting where your reimbursement is coupled to one or the other. Well, here in Belgium, and I think that this is quite of a nice thing to have. Well, everyone has reimbursements, whether you go to a university clinic, whether you go to a private clinic. So there are small amounts that change throughout the process in terms of finances. But these 6 cycles, you can choose as a patient where you do your cycle, but the reimbursement will be there. And this is a very, very unique setting. A full private IVF cycle in Belgium, like you have it in the US and in many, many countries, we don't really have that, which is quite protective for patients in terms of what can be requested from them financially. Because patients, they are desperate. If you, as a doctor, tell them, well, you need to take A or you need to do B, they will follow, and they will pay whatever you ask them to pay if you tell them that it will higher their chances. And patients also need to be protected for that. And that is quite of a luxury setting we have as a doctor in Belgium to give very correct information, because the reimbursement system is not depending on that.
What's also interesting to do then is what I hear you say, we have to also educate the general public, or our patients need to know about, at least fertility awareness, what to expect, etc. How do you see fertility literacy, if I may call it that way, globally? Because you mentioned Australia is doing good, but maybe perhaps because they have invested in that as well, in the educational aspect of things.
I think that's fundamental. And it's also something where, again, we're very happy to be here, because activities like what you do is crucial. We need to educate patients, potential people who do not even know that there might be a patient. I think it starts there. I'm of a certain age. I was only raised with don't get pregnant, and what is ways to not get pregnant. Where I think we should now, of course, continue to do so, and also next to that say, hey, there is also a limit to your fertility, and what should you know in order to take the right, what we call informed decision. You can still go to college and start first with a job and a career, or say, no, I want to do things before I'm 35 and then start having kids. But you need to know upfront what is going to be ahead of you. And that today, I don't know.
No. So you don't only come across that information when you're ready to have children. You need to start much earlier.
I think there are two essential moments. So in high school, where everyone is taught how to not get pregnant. So with the anti-conception, explanation, etc. I think it should be broader. It should be also a reproductive healthcare issue. Ladies as well, they would benefit of understanding their cycle. So one there, but then also when you are 30, 32, because this is the moment where you don't need to make any final decision, but at least then you need to think on how you will see your family planning afterwards. And if you don't want children and you are very convinced, this is fine. But if you have any doubt, you should know that there is AMH testing. You should know that you can vitrify your oocytes, because you should also not feel pressured at the age of 33 thinking, in a couple of years, I will be 35, 36. So, okay, this is the guy that I meet now. I want a family. So, if women are aware of all of these possibilities, they can make much better informed decisions. So, high school age, I think, in the normal educational platforms. And then around the age of 30, 32, actually, this needs to be repeated. And it needs to be with a very proactive question for ladies. Where are you now and how do you see your future? And these are all the options that you have.
I think that the role of a treating physician can be important there, or gynecologist. When you asked earlier, like what are barriers, what are hurdles, I spoke to important, what we call clinic chain, so a group of fertility clinics in Brazil. It was in January, and they are now literally going to reach out to gynecologists with a campaign so that gynecologists are motivated, triggered to have these conversations with their patients. And hence referral can be done on time, because that's also something where they say we see the patients too late.
How do you see your role in there? Because you have the role on the side of the doctors, for example, but Vitrolife Group on educating your patients, your consumers. What's your role in there? Because I think there is a lot to do on that side as well.
We actually have a department who does a lot of education, is known in the market also for the quality of the education. We call it the academy. It's majorly looking at embryologists, but also gynecologists, so the healthcare professionals. But we also have a part for patients, and both for what we can call the medical device, so the technologies that we have, but also for genetic testing. So we recently had a conversation with a president of IVFS, like how can we collaborate with IVFS to help them also, because they've got a high willingness to educate. So how can we be a partner in that? Because there's a lot of expertise within the teams. How can scientific societies are often restricted in the number of people that they have in their team. So how can we as a company put that expertise at the help of scientific societies, but also lay public, because we've got our channels through not TikTok. I don't think we do TikTok, but we do the other ones, even Instagram channels, where we then very meticulously ensure that the right information is being shared.
Because I think also, there is a collaboration needed. In one of the episodes before, when we were talking to MEP Sinabasa, we asked, okay, how can we do that? Because you can't only say it to the private industry, you need to inform or spread awareness, or the doctors or the public sector. It's a collaboration. Even to gain trust from the public, you really need to collaborate. And then the first thing is awareness and educating people before you can even build further upon that. You need that kind of foundation.
And I think it also becomes a political thing, because when you see fertility rates going down across the world and birth rates going down across the world, there was a period when I was a kid that there was an overpopulation, and that whole debate. We are way beyond that. That we are in a decline of birth. So it becomes a political agenda point. So I think there might also be a responsibility to be taken by the authorities.
Yeah, because a lot of that is also a question of funding. I must say that we are in contact with each other from the tech side and from the medical perspective side to get all of this information together with a lot of willingness from both sides. But indeed, you need to get it across. Creation of podcast, indeed being on social media. There needs to be a platform. There needs to be time. There needs to be energy. There needs to be money to do all these things. But I do think that there is a lot of communication already, at least between pharmaceutical companies, technological companies, and the medical societies. At least in my point of view, these are fruitful collaborations.
It's a very complex topic that we are covering that will make my next question a bit challenging. But if you could choose, or what is one policy, norm, or practice you can even choose that you would change to make access or even outcomes in reproductive health better, what would that be?
I think the dropout rates that I explained to you earlier, so patients giving up while they actually still have very realistic chances of getting there. This is my main frustration, because these are people who we can help, that because of the system or the way that the system works, because of a lack of support, drop out. And I really think that if they are fully informed, understand biology, physiology, their own bodies, and have realistic expectations, and the realistic expectations, this is a very challenging part, because of course you always balance between correct information and giving a patient hope. And if you are already prone, if you are primed, if you know that you will need probably 2-3 cycles, this is a completely different setting than when you arrived into IVF, did not get a lot of explanation, give yourself injections, feeling all of these side effects, just try, and then you get an embryo transfer and you're not pregnant. And then that explanation comes, but it's not always from the first time. A little bit older, we will probably need. So the correct information and setting expectations from the beginning is probably crucial. And this is, something that I would like to say, because this is something that we need to take care of as treating physicians. But of course, if you need to dive into the depths and into the complexity at each and every single consultation, it's very difficult. So there should be like this kind of introductory full class session before into IVF, because still a lot of couples do it and encounter one problem after another, while these are all very known things and in their experience sometimes a problem. But
so being better informed before you start the journey will not only make sure that people do not drop out, but it will also support them mentally, psychologically, as you talked about. That will also have a big role to play. What would that change be for you that you would like to implement or see in reproductive health?
I think awareness in policymakers, how important this perhaps reflects that they do an analysis of the reimbursement that they have today that was started, I don't know, a couple of decades ago. Is it still relevant? Does it need to be revised? As you mentioned, is there pieces that we can drop that is not relevant anymore today, but should be replaced by other things, other segments that are today not covered yet? I think there is lots. It would be good that everybody does that reflection from a policy-making perspective and then see what comes out of it.
Yeah. Based on everything that we've discussed here and the future projections that we just listened to, what's one word about reproductive health that you would like to send our listeners home with?
Hope. I really think the full circle, because it's very challenging, but there's also a lot of hope cumulatively over multiple cycles. And definitely when you are open to the entire treatment options that we have, also considering oocyte donation, for example, we can help most of the patients. It's often a very difficult journey, but often we succeed. And I think that one thing that is also crucial for the future is that people going through IVF or going through vitrification cycles should just talk more about this. And then it will come up higher in the political agenda, and you will not feel so alone. You will not feel like you're the only one with a subfertility problem, freezing your oocytes, because you are not. Our waiting rooms are full with patients, but we need to break the taboos on fertility treatment, on pregnancy loss, etc.
Being hopeful,
being hopeful, and sharing grief and experiences, with the correct medical guidance.
I would answer 3 words. It's the power of innovation. Hope is one thing in medical. The care is fundamental. But what today can be done through innovation, through technologies that were not there a decade ago is proven in research. So I think those go hand in hand. It's a very young pathology still. I read a document that in the 80s there was a 15% chance of getting pregnant, like that. That grew throughout the 90s. We're now 2025. Like best centers of expertise get to 50%. You mentioned
and
when
higher,
higher.
GTA.
So that is a good momentum. That shows that things can improve, and that's also what we as a company want to contribute to. That those outcome rates, on average, get higher.
The quality of the lab is essential, and there, of course, we collaborate to a high extent. But you have to work with the potential of the gametes that you have. But you need to take care of them to the best of possibilities, and a standardized lab in highly controlled environments, it leads to better embryos.
That's a very hopeful way of wrapping up this episode. I think there is indeed still a lot to do, but there is a lot of potential and opportunities lying in front of us to make some change and make use of this momentum as you described. So thank you very much for taking the time of your busy schedules to share your insights with us. I think this is a first step for us, or to spread awareness. It's a fundamental step to make sure that people are informed and know about all of these stuff. So thank you, both of you, and I hope you enjoyed it as well.
I definitely enjoyed it. Thank you for creating this platform. Very happy that I was here to talk about this subject.
I gotta say, for me, it was really nice. We should do more of this.
Definitely, I hope so. Thank you very much, and I hope to hear everyone and see everyone at the next episode of Women's Health Uncovered.